Hi, good evening, everyone. So we are back again after a break of 1 week because I was busy with the NAMS quiz. And this Saturday, we'll finish our series on epidermolysis bullosa. We have completed epidermolysis bullosa simplex, junctional, and dystrophic in separate videos each and every week, and also diagnosis of epidermolysis bullosa as a separate video in the middle of the week. This Saturday, we'll focus more on approach to the patient, not per se particularly approach, because if you go through the basic three videos of simplex, the junctional and dystrophic EB, you will realize that they may feel similar in pathogenesis. For example, the defect in pathogenesis is only the defect lies adjacent to each other. Only a nanometer or micrometer difference is there. Okay, and this can lead to a plethora of different clinical manifestations. But if you go through those three videos, you'll be easily able to distinguish between junctional dystrophic or simplex forms of EB. Now, we'll go through differential diagnosis of epidermolysis bullosa. We'll go through the modalities that we have to take care while managing a case of epidermolysis bullosa. Most of you will not see a case of EB dystrophic or EB junctional during their training. That might be a possibility, especially if you're not working in a tertiary care center. Now, most of the time, when you come across a case of a baby with epidermolysis bullosa, the main problem lies with the not repair per se, but make sure that the barrier is taken care of. The baby doesn't have a good barrier. The skin is not okay, and because of that, all the complications will start arising. So the first complication that the baby will have is because of the skin not formed properly. The other complications are the intense scarring, which on the skin will present as contractures, while if it is internal, like in esophagus, you have esophageal strictures and anal strictures and all sorts of things. The third and the most important complications are erosions. They are painful erosions and they are difficult to heal erosions. Okay. The other complications is psychological support, both to the patient and the family, because both of them will require psychological handholding. So that is also important. So what the problem arises when we have to write a short note on approach and management of EB, because so much there is to write. So I thought that I'll discuss it in an orderly fashion so that if a short note comes on how to manage a patient of epidermolysis bullosa, then we can easily enumerate the modalities and then write few lines about it. So you can easily write a short note or even a long answer question. We used to get a long answer question on the management of epidermolysis bullosa, pathogenesis and management. But if you go through these 5 videos, the simplex, junctional, dystrophic, diagnosis and management, the concept of epidermolysis bullosa would be very much clear. And when you combine these videos with the videos on basement membrane zone, your concept of inherited bullous disorders is clear. Okay, so without much further ado, we'll start now to approach and management of epidermolysis bullosa. So epidermolysis bullosa is a genetic disorder. It's a genetic disorder with variable expressivity. Do we mean by variable expressivity? That means a single gene mutation can be expressed in different gradations, different intensity. A person with creatine 5 mutation can have a certain intensity of disease, while another individual with the same mutation can have a different expressivity or different intensity of disease. So because of this variable expressivity, it becomes the management has to be tailored from patient to patient. Okay, it is a patient specific management. Because of consanguinity, the chances of recessive disorders increases. Okay, and there are certain sections of society in which consanguinity is more probable as compared to other sections, and that can lead to rampant recessive disorders, including epidermolysis bullosa. Many of them are recessive disorders in in uh, in their inheritance. Now, EB as of now has no treatment, only management. So this is very important. Make sure you write it if you're writing it in your exams, that no treatment as of now is possible. It's only in the research stage and only management of complications are there. And we'll talk a bit about gene therapy. So that is how we're going to go through in this lecture. So before we start, we'll go through this flowchart in Bologna. It's on page 543. and it shows helpful cutaneous findings in patients with EB. Personally, I didn't like this flowchart because everything is jumbled here. Okay, it's nothing in order. You have the junctional EBs, then simplex, simplex, then junctional, then simplex, then dystrophic. But the importance of this flowchart lies in the clinical manifestations, which can point you towards a certain type of EB. For example, if there's a primary involvement of palms and soles, it could be EB localized, EB simplex localized, because only the local areas are involved. If there's primary involvement of axilla and groin, then it's the inverse type. Remember while we were studying junctional EB that there is an entity known as GV inversa, in which the inverse areas or the fold areas are affected. It can also be seen in recessive dystrophic EB inversa. You have to just remember that the involvement of the body folds are more in inversa type. Grouped or herpetiform blisters, sometimes in a figurative way. It is generalized severe EBS. So if you remember again the video in which I had a diagram of a baby boy and I showed that there are herpetic lesions or grouped vesicles over the trunk. So it's more likely towards EBS, generalized severe. Okay. If there's reticulate hyperpigmentation, it is EBS with moderate pigmentation. Again, go back to the video. So these are the, you could say, specific clinical findings that can easily point you towards what type of EB you are dealing with. Excessive exuberant granulation tissue, especially at the periorificial marks or around the mouth, eyes, and around the anals. Axilla, neck, and upper back. So remember the video few weeks back on junctional EB, in which I said that the more granulation tissue is seen in junctional form. So junctional EB, generalized severe. If there's confluent palmoplantar keratoderma, then it is a sign of EBS generalized severe. So we have seen two distinguishing features of EBS generalized severe. One is herpetiform vesicles and other is palmoplantar keratoderma. Okay. Prurigo-like nodules into linear plaques on the shins is a feature of dystrophic EB pruriginosa or EB pruriginosa. So 2 weeks back, when we were discussing the dystrophic EB type, I discussed a subtype of dystrophic EB, which is EB pruriginosa. Okay, and in that dystrophic EB, you see prurigo-like nodules on the shins. So if you see that in an adolescent patient, you might consider a dystrophic EB pruriginosa, at least in your list of differentials. Okay, so this flowchart will show you distinguishing cutaneous findings which can point you in some direction. Of course, you have to take into account, and I would very strongly suggest that you use EB matrix to clinically make a diagnosis or at least list of differentials while evaluating a case of EB child. Okay. Okay, so this diagram I've taken from Rook's 10th edition, page 69.24. And this diagram enumerates differential diagnosis in a child with blistering disorder. So if you see blistering in the neonate, okay, just go through this area, this flowchart, not flowchart per se, this diagrammatic representation. Look for infection. So infection divided into three parts: bacteria, fungus, and viral. Okay. In bacteria, staph, strep, E. coli, Klebsiella, Haemophilus, Listeria, Pseudomonas, syphilis. Now remember, syphilis. We already have a video on congenital syphilis on the channel. And in congenital syphilis, it is the only form of syphilis in which vesicles are present. Okay. Remember, we discussed congenital syphilis while discussing the syphilis series of videos. And this is the only type of syphilis in which vesicles are present. So a child born with vesicles and erosions can very well be a case of congenital syphilis, especially if the mother VDRL or TPH is positive or there's a history suggestive of syphilis. Okay. But remember, the bacterial infections would be acute. But if it's happening in a neonate, you don't have a clear understanding of acute and chronic because the lifespan is, or the life duration is not that large, not that big. So you might not be able to distinguish between acute and chronic. But these are the differences to keep in mind. Even superficial candidiasis and malassezia infection can lead to erosions per se, not vesicles or blistering, but maybe erosions. Candida over the mucosa can cause significant mucosal erosions, which can mimic epidermolysis bullosa. In viral, you can have herpes simplex, congenital varicella, cytomegalovirus, Epstein-Barr, Coxsackie. So these are all viruses that can present as bulla or vesicles. Okay. Now these are the infection part. Then you go with genodermatosis. Genodermatosis include epidermolysis bullosa that we're discussing right now, epidermolytic ichthyosis, which we'll might discuss in a future video, and incontinentia pigmenti, especially the vesicle stage. So IP has roughly 4 stages, and most of the time the baby born is in the 4th stage of atrophic scarring stage, but the baby can be born in the vesicular stage of IP, where they will have somewhat of a Blaschkoid distribution of vesicles over the body. So that can also mimic clinically epidermolysis bullosa. Now, autoimmune disorders, including congenital pemphigus or neonatal pemphigus, neonatal pemphigoid, bullous pemphigoid can be there. But here the biopsy of the lesion would be able to help. Okay, biopsy, even immunofluorescence can help. Okay, metabolic disorders like acrodermatitis enteropathica and aminoacidureas usually have periorificial dermatitic-like lesions, or periorificial erythematous erosions can be seen in acrodermatitis enteropathica or aminoacidureas, which can clinically mimic EB. The last is inflammatory. Inflammatory, for example, miliaria, erythema toxicum neonatorum, transient pustular melanosis, sucking blisters, urticaria pigmentosa. These can all present as vesicles. But remember, this will be acute in origin. There will be associated symptoms, and they will start to resolve in 1 or 2 days or 1 or 2 weeks, while EB will keep on getting worsening with time, at least over the course of few weeks. It might eventually regress when a child grows older in some of the subtypes of EB. Okay, so we have enumerated all the differentials. What I'll do is I'll remove the markings so that if any one of you would like to take a screenshot, so you can. But this exact figure is available on Brooks 10th edition, page 69.24. Okay, 69.24. I think that should be enough. Clear? So let's move forward. Now, see, we have discussed and distinguishing features of different subtypes of EB. We have discussed differential diagnosis in a neonate with vesicles and blisters. Now, from henceforth, we'll discuss the management of EB child. Okay, and this diagram I've taken from this article, Epidermolysis bullosa, practical and clinical tips from the field. So many of the times we might, in counseling to our patients or the parents of a child with EB, you can tell all things which might help and make their life easier. For example, no bugs. So the child must sleep inside a mosquito net so that the mosquitoes don't bite. There's no inflammatory response. We don't want the child to scratch himself because the skin will come up. Cool room. Now remember, many of the EB subtypes, heat and sweating can exacerbate vesicles. So it is imperative that the child sleeps in a cool, air-conditioned room. Similarly, there should be a heat reflective roof. Make the environment as cool as possible. Not cold, but as cool as possible. Now, bean bags will lead to less trauma. So no hard furniture, okay? No hard furniture, just less trauma. So there won't be any pressure on the bony prominences. For example, if a child is lying down or sitting, the pressure would be there on the bony prominences, and erosions and chronic non-healing ulcers can happen there. So it's better if we invest in bean bags. Wi-Fi and video games. And this is one interesting point. Wi-Fi and video games to keep the child busy and entertained. See, life with EB is very tough for the patient, very tough for the family members. So if we keep them entertained and happy, that would be much better for them. It will reduce the inclination to scratch oneself or to keep on picking at the erosions so that the healing is not delayed. So keep them busy, keep them happy. Reduce sugar. So sugar has been found to increase the inflammatory state in various articles. It has been shown that increased sugar intake in childhood might increase the inflammatory response. and consequently the erosions would get severely inflamed around the edges, leading to prolonged non-healing of the erosions. So reduce the sugar intake and smoothies. So you need a good blender to smooth everything out. Now, what is the reason behind using smoothies or recommending smoothies is that a growing child requires proper nutrition. And because of mucosal erosions, because of vesicles around the mouth, because of esophageal strictures, because of any gastric or GIT strictures or ulcers or erosions, they may not be able to feed properly. So they need to have their nutrition, and for that it's better to blend everything and give them in a smooth paste-like consistency so that they can easily swallow it without any trauma to the inside of mucosal areas. Okay, so this diagram I found to be very interesting, so I thought I'll share it with you. Let's move forward. Okay, so from henceforth, I have divided management into two parts. One is modalities for management, that is how to manage a patient with EB simplex, with EB group of disorders as of now. And the second part would be modalities for treatment of EB simplex. So this part A, okay, part A here will be modalities for management. And this is more practical aspect, okay, practically what you can do for the baby. So this is more practical aspects. So I've divided into, not divided, but I've enumerated what are the practical modalities for management. You have to manage long-term complications. We'll discuss them in detail, don't worry. So we manage long-term complications. We have to take care of the wound, pad them, wrap them, dress them. Okay, pain management of the erosions is very important. Sepsis care. Because of intense erosions, the child is prone to develop sepsis and infections. So that needs to be cared also. Prevention of contractures. Remember, in subtypes of junctional EB and dystrophic EB, the significant scarring and fibrosis can lead to contractures. So much so that either the entire limb is not useful or the entire limb might be lost. So daily routine activities has to be continued. Either you help them, you have to make sure that the contractures don't happen. You make sure that there's no problem in mobility. You have to make sure that any chronic non-healing erosions or ulcers on the hands and feet are properly managed. Ulcers on the feet are usually do not cause any much problems because you don't require much mobility to move around. But your hands are very important, so make sure those do not suffer from contractures. Prosthesis and mobility has to be ensured. So make sure that if the limb is lost, then they should have tools to carry out their daily activities so that they can develop a good self-dependence and to carry out their daily routine activities and function. Now, psychological care is very important for the child and for the parent also, for the family members. So, for the child, it is important because it's the patient who is dealing with these disorders, so they should have good psychological care. While for parent, it is important because they have to provide that care to the child. They have to make sure they understand what is the level of problems and what are issues that might creep up in the future, and they should be ready for that. Psychological care doesn't happen on the first visit. It happens on every visit. So every time the patient comes to meet you with their parents, counsel the whole family. Okay, they require proper support. All the resources have to be shared with them, educational resources. Make sure they don't fall into wrong informations. And regarding this, we'll talk about Debra, but we'll talk about Debra at the end. Okay, so stick around and I'll talk about Debra. Genetic counseling. Genetic counseling is mainly for future pregnancies, not the current pregnancy. So, if there's a possibility of knowing the genetic makeup of the next child, you might decide to either carry on with the pregnancy or maybe stop it in between. Okay, so these are the modalities for management, and let's discuss them in detail very quickly. So, discussing first the long-term complications. In the oral and GI complication, we have excessive caries. Remember, a lot of EB simplex have dental abnormalities in the form of enamel pits or even enamel loss. And these pits and loss can lead to caries. Even gum erosions can predispose to caries. So for that, you require diligent oral hygiene, antiseptic and fluoride mouthwashes. So fluoride actually strengthens the enamel when fluoride is used in a very small concentration every day, it strengthens the enamel. Periodic evaluation and cleaning by a dentist. Okay. And that I will mention that electric toothbrushes are actually recommended. Electric toothbrushes are recommended so that the ability of the child to put more pressure is actually reduced. If you use a non-electric toothbrush, they have a habit of rubbing and the bristles are very hard. In electric one, you can go for soft bristles so that the mucosa is not damaged. Management can be by restorative dentistry. They can be implants. They can be correction of dental erosions. Okay. Microstomia. Microstomia is that the child is not able to open the mouth fully. The mouth opening is small. So physical therapy and mouth expanding devices so that gradually over time, one can expand the mouth opening. Oral ulceration. Topical antiseptics, topical NSAIDs to manage pain, barrier preparation like sacralfate suspension so that it can create a barrier between the over the ulcer so that it's not painful. So all you have to do is manage that there should be no secondary infection and there should be no pain. Okay. So in India, you can use anesthetic gels, which we routinely use in patients with pemphigus or bullous pemphigoid oral erosions or aphthous ulcers. So all kind of anesthetic gels can be used. In managing esophageal strictures, you have to evaluate dysphagia with contrast studies. For example, barium swallow, like we do in systemic sclerosis, can be done to find out the level of the contractures. You modify the diet by pushing to soft food. Again, blenders come here. Okay, so blenders are actually important. Fluoroscopic guided balloon dilatation so that you can dilate the strictures. And in severe recalcitrant cases, you can have surgical removal of the stricture part and connection of the anastomosis. So that can also be undertaken in select cases. In gastroesophageal reflux disease, PPIs to be used, H2 blockers to be used, prokinetic agents like metoclopramide and domperidone to be used. It is easily available here, not in the US, but in India, these drugs are easily available that can be used if required. For constipation, ensure adequate fluid intake and dietary fiber. Remember that the same issue, the microstomia, is also affecting the anal opening also. Okay, so laxatives and avoid suppositories and enemas because that can lead to excessive dilatation of the anal orifice, leading to erosions and fissures. So that should not be done. It's better to counsel the patient to take soft diet, fluid containing, fiber containing diet, or osmotic laxatives. So these were the GI complications. In nutritional complications, you can have growth retardation, inadequate intake to meet nutritional needs. Remember, because of the low opening of the mouth and strictures of the esophagus, the child is not able to eat properly. So you monitor the biochemical, the biometric pathways like weight, height, and body mass index. You assess the micronutrients like zinc, iron, vitamin D, oral supplements so that you can optimize the intake of calories, proteins. You blend everything up and feed the child. If the patient is not able to take food through mouth, you might consider gastrostomy feedings so that at least the nutritional requirements of the child is met. Let's move forward. Anemia is the most common hematologic complication in EB. Okay, and that is due to iron deficiency, predominantly because of diet and chronic inflammation. Now, in anemia of the EB, especially in dystrophic EB and junctional EB, the anemia is found to be anemia of chronic disease. Okay, or okay. So for that, you have to monitor CBC and measures of iron stores. In fact, it has been shown that we should measure serum iron instead of serum ferritin. Okay, because ferritin can also be increased in chronic inflammation. So serum iron is a good measure to find out if there's any iron deficiency or not. To supplement iron by oral or IV, the muscular route, the IM route is not preferred because it can lead to a lot of erosions and the lot of even abscess formations have been reported. So iron supplementation should be done by oral or parenteral IV route. Consider erythropoietin or dalbavapoietin alpha. These are all agents to increase the production of RBCs. And if the hemoglobin is less than 7 to 8, you consider blood transfusion like you do in any case of anemia. In in genital urinary and renal issues, the first is urinary flow obstruction. Again, the stricture is causing an issue here. Okay. Consider annual ultrasound of the urinary tract to see if there's any kind of stricture. You can do urodynamic studies to look at uroflowmetry or the flow of the urine to find out strictures in the urethra, and dilation procedures can be done. Renal diseases like hydronephrosis, post-infectious glomerulonephritis, and renal amyloidosis and IgA nephropathy should be considered. For that, you just have to measure KFTs, maybe annual KFTs, biannual KFTs, okay, and you treat other infections and underlying causes. If the kidney is significantly damaged, you can consider hemodialysis or peritoneal dialysis if failure is imminent. Okay, so this is how you manage renal complications in long-term EB cases. In musculoskeletal, you can have osteopenia and osteoporosis predominantly because of vitamin and calcium deficiency. For that, DEXA scan is the investigation of choice and radiographs so that you can find out whether osteopenia and osteoporosis is setting in. Consider IV bisphosphonate therapy as treatment. Always add vitamin D, calcium to a child of EB. Okay, vitamin D plays a very important role in inflammation, in curbing inflammation, in good process of keratogenesis. So, keratinization process is very much mediated by vitamin D and calcium. So make sure that deficiency does not occur in a child. Pseudosyndactyly of hand and feet. Remember when we were discussing the dystrophic one, that let's say this is the hand, and if there are chronic non-healing ulcers leading to fibrosis, so much so that these fingers actually get fibrosed together, you can have a mitten shape deformity. Okay, so this is a mitten shape or a mitten deformity, mitten shape deformity. Okay, now syndactyly is when the fingers are not separate during embryological development. But since here the fingers were separate, they just joined together, it is known as pseudosyndactyly. Okay, let's move forward. Surgical correction has to be considered to manage syndactyly, but best is that you don't allow syndactyly to actually develop. Cutaneous squamous cell carcinoma. We'll discuss that in detail in one slide. Don't worry. You just have to examine total body, frequent examination every 3 to 6 months, and you begin at the age of 10. However, some guidelines recommend that after 5 years of age, annual screening is a must. After 10 years, you may increase the frequency of screening every 3 to 6 months. Biopsy any non-healing ulcers and take photographs so that you can have photographic evidences. You manage squamous cell carcinoma like you manage any other squamous cell carcinoma. The difference is that SCCs in EB patients, especially in dystrophic recessive patients, are very aggressive. So make sure you do a PET scan CT so that you can find any mets. If I remember correctly, about 35 to 40% of the cases can have metastasis to other areas. So make sure you do a baseline PET and a CT for evaluation. Okay, let's move forward. Ocular complication in the form of corneal scarring, symblepharon, ectropion can happen. You have to give lubricating eye drops to all patients of EB and periodically evaluate eye for any kind of problems. Surgical procedures can be considered if the lid has fibrosed because of intense scarring. So that has to be corrected surgically. Amniotic membrane transplantation have been used to manage corneal ulcerations or erosions. Okay. Heart can show dilated cardiomyopathy, so you consider annual echocardiography to find out the onset of cardiomyopathy. So you manage as any other case of cardiomyopathy, you supplement selenium and carnitine if there's any deficiency. So this is how you manage different long-term complications in an EB child. Again, very important psychological and psychiatric support. Disrupted family unit. Of course, there will be issues among the parents because of the child they have to care. They are stressed. They are not able to handle properly. So they have to consider family counseling, support groups. Make make sure that they know that they are not alone. Help them. Okay. If they require proper psychiatric counseling or psychiatric treatment or psychiatric evaluation or evaluation, so they must be sent to a proper registered psychiatrist to help them out or proper registered psychologist to help them out. Depression and self-harm ideation are very known. So you have to consider psychological counseling. There's no harm in referring the patient towards psychological healthcare professional so that they can help the family and there is no family disruption. Okay, so we have finished the long-term complication in an EB child. We now focus on wound care. Remember, most important is to restore the barrier. The barrier has been lost because the skin is not forming properly. The formation is not adequate, and the skin is getting separated from the underlying layers, leading to erosions and chronic ulcers. Okay, so we have to restore the barrier. The nursing care has to be expert. There are qualified EB nurses. There are actually training programs to train nurses and doctors to care for a EB child. There are very well known centers in which EB children are kept and they are counseled and properly taken care of. They even provide training sessions for other healthcare professionals. So if your center is dealing with a significant population of EB child, they should have a qualified EB nurse to take care of them. Use thick foam pads covered with silk sheets for staying of the child and feeding of the child. So what we actually mean is that you should have a thick foam pad here. Okay, let's say this is a thick foam, and then you cover it with a silk sheet. Silk sheet. Okay, and the baby lies here. So you have the head, the torso, and let's say limbs. Excuse my drawing, but understand the concept. Okay. So whenever you have to pick the child, you pick the child with the foam mattress or with the foam and silk sheet along. You don't pick them directly because you will rub against the skin and the skin will peel off. So make sure you use the mattress with the silk sheet so you can pick them up for staying or for feeding. Normal saline gentle cleaning of erosions followed by non-adherent dressing. Remember, it has to be non-adherent. Adherent dressings, while removal, can actually peel the skin off. So non-adherent dressings. Topical antibacterials like stabilize H2O2 to clean the area, 1% chlorhexidine cream, 1% silver sulfadiazine cream. Now these can be used. But remember, long-term usage of any antibiotic can prone the patient to antibacterial resistance, especially in EB child who are more prone to sepsis and bacterial infections. So keep that in mind. Also, many of the time the dressings are impregnated with silver. So if you use silver dressings for a long period of time or over a large surface area, there is a chance of systemic silver absorption causing argyria. So make sure that you keep this in mind while treating a child with TB. And if you want to, clean the wound, use an antiseptic. It's better to use antiseptics which are not antibiotics so that you don't push the bacterial resistance for the child. Okay. So mupirocin can be used for a shorter duration because if you use them for a longer duration, it can cause the rise of resistant staph aureus. Okay. There are two trademarks that usually people use, Mepitel and Mepilex. These two are mentioned in books also. Mepitel is porous, that means it has holes in between, and mildly adherent silicone-based material. So what actually Mepitel is, it's like a mesh-like structure, and on that, over that, you put a gauze which is absorptive. So the fluid actually goes through the first mesh and gets absorbed by the gauze. And this Mepitel has to be changed every 7 days. Okay, so every 7 days it should be changed. Mepilex is a foam backing for protection and absorption. For example, let's say this is the foot of an EB child. So you put Mepilex dressing here. Okay, and this Mepilex dressing has foam, so it will also provide protection to the bony prominences. They have to be changed every 24 hours. Give them cool environment. We have already discussed that heat and sweating can actually increase the erosions. So cool environment. Cotton socks, soft insoles inside the shoes. In fact, some mention to use two socks so that there's enough padding while the patient is walking. Cornstarch, simple cornstarch can actually absorb the sweat so that there's not much damage. It may provide a bit lubrication also because it is slippery, easier for the child to move about. So cornstarch can be used. So these are the some of the Mepilex dressings. If you go to this URL, this is the URL for the website for the Mepilex company, and Mepilex company has a lot of different shapes and sizes of dressings. So I thought that I'll show some of them. This is Mepilex sacrum. This has to be put on over the sacrum, over the lower back. This is Mepilex heel because in Mepilex, okay, so this one is sacrum and this one is Mepilex heel. Sacrum. So you can see the shape. This it is like a leaf shape or heart shape. So over the lower back it sticks, while the heel one has a constriction in between, so that it can curve around the heel and provide support. Okay, this is Mepilex AG, that means silver impregnated, it is gray in color. And this is Mepitel. I've changed the color so that you can see, because Mepitel is actually transparent. So I've changed it into black and white so that you can see the porous mesh-like architecture of Mepitel. So these are the dressings available. Other dressings like soft silicone dressings or non-adherent lipo-colored dressings, hydrogel dressings, they can even provide moisture so that if the wounds are dry, they can provide moisture. Okay. Foam dressings to absorb the amount of wound exudate. Absorptive dressings do the same function. Silver containing dressings we have discussed, it decreases the chances of infection. Other antimicrobial dressings, for example, if the wound is already infected, you can use these kind of dressings. And these kind of dressings, for example, in private practice, we routinely use to manage chronic non-healing ulcers or post-surgery. Okay, but these are a boon for EB child. If there's extensive granulation tissue, like we see in junctional EB, topical steroids have found to be useful. Yeah. So topical steroids are useful. For problems in teeth, gentle cleaning, electric toothbrushes, soft bristles, chlorhexidine mouthwash, fluoride toothpaste, implants, and if there is attachment or fibrosis of the tongue so that the tongue sticks to the floor, there can be surgical correction to be undertaken. Any complication of the eyes have to be urgently managed or there will be vision loss. Okay, so any complication of the eyes has to be managed by topical antibiotics, artificial tears, padding can be done so that the lids don't adhere to each other, and surgical correction of any eyelid disorders. Mitten deformities, contractures, or pseudosyndactyly have to be surgically corrected. To prevent pseudodactyly from happening, you can have padded gloves, so the patient can wear gloves so that can protect from trauma and keep the fingers separate also. And any ulcers occurring in between the fingers have to be properly treated. So for pain, you can use opioids, amitriptyline, benzodiazepines, psychological support, and intense hand holding. That is very, very important. Now, genetic counseling. We'll discuss it very shortly. In genetic counseling, it is done only for future pregnancies so that you can avoid another child with EB. So, okay. So, sample for genetic counseling or sample for genetic testing is to be done. So, what you can do is you can do chorionic villus sampling as early as 8 to 10 weeks of gestation and amniocentesis as at second trimester. Okay, so you take out the some of the cell samples during the pregnancy and then check if there's problem or there's mutation in the developing fetus and then counsel them accordingly. Okay, so that is how you have to counsel. But genetic counseling also includes psychological counsel. Okay, so that is also important. And you have to counsel the patient that it is a genetic disorder, it happens due to mutation, it can happen to anyone. There are instances of sporadic EB, so make sure you counsel them that it is just because of fluke of few nucleotide pairs that is happening. Nothing of their fault per se. As of now, fetal cells in maternal circulation are also being researched so that we can do genetic testing on that. What actually happens is that when the mother's blood get mixed with fetal blood during circulation or during pregnancy, some of the fetal cells come inside the maternal circulation. And when they do, they get mixed up. And when they get mixed up, those cells can be taken out from mother's sample. Okay, so what actually we are doing? We are taking fetal cells from mother's blood sample. And then we have to look at the genetic material and see if there's any mutation or not. But remember, genetic counseling and genetic testing are only for future pregnancies, not the current one. So now we'll discuss the genetic counseling part. This is autosomal dominant pedigree. So I thought I'll just cover very quickly how to find out whether the pedigree is autosomal dominant or autosomal recessive. Okay. For autosomal dominant, at least one of the parent has to be affected. One parent has to be affected. It has to be affected. So if all the affected individual will have at least one affected parent, it is autosomal dominant. And since every affected parent or the affected patient will have at least one affected parent, There will be no skip generations. What do we mean by skip generation? That means disease has affected one generation, then none of them in the second generation, and then one again third generation. So the second generation becomes skip generation. But since in autosomal dominant, you require to have at least one affected patient, there are no skip generation. In contrast, when we see autosomal recessive, they can be skip generation because both of them can be carriers, and none of the carriers would develop manifestation, but their offspring would. Okay, so that is how you know about autosomal recessive, and that is important because remember, the recessive forms of EB are much more severe. Okay, they are much more severe in manifestation. Okay, so I think it's already 40 minutes, so we'll take a short break and we will continue the modalities for treatment in part 2 of the video. I'll try to shoot it and upload both of the parts together so that you don't have to wait. But let's take a short break, have some lunch, dinner, breakfast, whatever time it is. Take a short washroom break, and then we shall be back for the part 2 when we'll discuss modalities for treatment. Till then, go and come back as soon as possible.